I'd like to introduce our next speaker, Dr. Yves Longtin, who's an infectious disease specialist and a medical microbiologist. He's the chair of the Infection Prevention and Control Unit of the Jewish General Hospital in Montreal and the president of the Association of Medical Microbiology and Infectious Diseases Canada, or AMMI, as you all know. Let's welcome him, and we get to listen to him tell us to bug off how infection prevention keeps resistance in check. Thanks, Yves.
Thank you for the kind introduction. Thank you for the invitation. My slides are far. Is it possible to swap the display so that the slides are here instead of there? Am I the only one who had the same struggle? I would hit swaps display once. No? Okay, so you may see my profile a lot, so I have to look at the slides there. So I have to remove my glasses as well. Age. So thank you for the invitation. I'm aware that probably not many of you are involved actively in infection control. So today is an opportunity for us to review what is the role of infection prevention and control in fighting AMR. These are the learning objectives. I'm going to go a bit faster. I know we're a bit late on the schedule. And also a bit late in the program in the sense that you've already seen a lot of similar slides. But the goal here is to see a little bit the burden and the role of IPAC and some challenges and potential solutions to these challenges. These are my conflicts of interest. I don't have any conflict of interest with the industry, some involvement in scientific organizations. So some definition and some magnitude of the burden. Just what is AMR? And just to remind people that it is a natural process, right? It's not an artificial process. It's been there since the dawn of time. What is abnormal is the acceleration of the resistance process due to human activity. So why are we saying that this is a natural process? Well, don't forget that the vast majority of the antimicrobials we're using right now are actually derivatives of naturally occurring substances in the environment. And for how long they've been around, we're talking hundreds of millions of years and probably even billions of years for the beta-lactam antibiotics. So they've been around for a long time. Microbes have been fighting one against the other using antimicrobials and resistance enzymes since the dawn of time. It's survived all the great extinctions. It's been there. It will be there forever. So when do we start talking about AMR? When is it abnormal? I think it's important to highlight that this is a moving target. We're constantly adding microbes to the AMR list, and we're also taking off some of these as well, because it's a constant process. Right now, we're really afraid about MRSA, VRE, the carbapinamase-producing organism that we call the CPE, the new kid on the block, Candida auris, which we haven't spoken much today, but it's a new one. But there has been threats. We used to worry about gentamicin-resistant Enterococcus. I don't think it keeps anybody awake at night currently. Or instead spectrum beta-lactamase Enterobacteriaceae, with ESBL. Some countries are really worried about them. I think in Canada it fell off the radar a little bit because of this CPE. The burden, you've probably seen these data. They've been cited a lot. From the Lancet Infectious Disease publication that look at close to 1 billion data set in 200 countries to estimate the burden of AMR. And well, we're going to skip directly to the conclusion, which is currently it kills 1.3 million people a year worldwide. And how big is that? Well, we have to put this into perspective with other big killers. You may be surprised to see that nowadays, HIV kills approximately 700,000 people a year worldwide, and malaria 600,000 people a year. It used to be millions, right? But now we're under 1 million for each of these two diseases. So nowadays, AMR kills more than malaria and HIV combined. So it is a new threat. Canada-wide, we're talking about 4,500 deaths currently. And when you put this into perspective with the other causes of death in Canada, well, I'd like to say that we're a big threat, but we're way down the list, right, at 5,000. We're still very far from cancers and heart disease, which kill much, much more Canadians. The difference is the outlook for the next 25 years. The next 25 years, the forecast is that this number, 4,500, is going to double to 8,000 over the next 25 years. Whereas the other causes of death will remain relatively stable other than just increasing population size. So this is the threat. And we're not putting any money into controlling the AMR. These are very interesting data, an infographic from the Lancet that published that showed that where are we putting the money right now, the blue columns on the left, you see that we're not putting a lot of money on AMR. We're putting a lot of money on TB, HIV, AIDS. But let's compare this with who is dying from what. And you see that there's a complete discrepancy about where we're putting money right now versus who is actually dying from these diseases. We're going to have to realign this. So that had to happen. So how do you stop AMR? Well, my perspective is infection prevention and control. So we have a lot of tools to try to prevent the spread of these microbes. If we look at the CDC, regarding the main ways to prevent AMR, the first one at the top that they put in their infographic was infection prevention and control. Stewardship was a bit lower. They were not hierarchical, don't worry, but I'm just teasing. But antibiotic use and access to the new antimicrobials was also on the list. So the Canadian Action Plan is also putting infection control as one of the 5 pillars of the fight against AMR. And of course, what causes an antibiotic resistance? Bad infection control causes resistance worldwide. That's per WHO. So is AMR mainly a problem of the community or a problem of healthcare settings? You've seen data, you've heard data that 85, 90% of all the antimicrobials consumed worldwide is in the community. Very small proportion are in acute care setting. So is it really a problem of hospitals or a problem of the community? Well, if we go through just pathogen by pathogens and we go through the list of the main threats in terms of the main antimicrobial resistant threats as per CDC, you get to about 21 pathogens identified by the CDC. And we can classify them in terms of where do these occur, community versus the hospital. And it's about half and half. So pathogens like the CPE, the MRSA, the VRE, they mainly spread in hospitals. Of course, there's others like Shigella or Streptococcus pneumoniae that's resistant to penicillin, or Group A strep or Group B strep that are mainly community-acquired pathogens, but about half of them spread in hospitals. I'm going to skip that just to make it. So how do we stop? That was a big stop sign. So what is the role of IPAC to stop these things? Well, we have a lot of roles. For those of you who are not super familiar with our specialty, but we do surveillance, collecting data, auditing and feedback, which is also super important with the panel about audit and feedback of prescription habits, but also of hand hygiene, for example. Education is important. We write all the policies and procedures, control outbreaks, monitor outbreaks, and make sure the environment is safe. And for each of these strategies, we have a lot of tools. Some tools like hand hygiene you've heard about, contact precaution, screening, isolation, the use of private rooms, dedicated staff. How do we articulate them, however, is always a matter of debate. And within the infection control community, there's always this debate about should we go vertical or horizontal? Now you're all looking at me like, what is this? So there's 2 main ways to tackle the spread of microbes in hospitals. A vertical approach is to target one particular pathogen and do everything to fight this pathogen. Think MRSA, screening on admission, isolating the colonized individuals, decolonizing them. This is a group of strategies that will together target MRSA only. Another approach is to go horizontal and say, I'm going to instead put my energy into hand hygiene promotion overall. This will target all the pathogens at the same time. So this is what is called a horizontal measure. There's always this debate about should we go vertical or horizontal. There's some pathogens for which there's no question, right? If you had a Candida auris outbreak in your hospital, I'm pretty sure everybody would agree that you have to go vertical and screen and isolate. But for pathogens like VRE, Then people start debating, well, it doesn't kill that much. What is the most cost-beneficial impact approach? So there's this ongoing debate about these two philosophical approaches to infection control. The question of cost-benefit is also something that is challenging in infection control. There are some systematic reviews that say that infection control is highly cost-beneficial, which always makes us very happy, and we can show them to our CFO. Other studies, though, like the systematic review that was published 2 years ago in Lancet Infectious Disease, had much more cautious conclusions. They identified 73 studies looking at cost-benefit studies for infection control. Most of them were from high-income countries, and they had very heterogeneous results. They had results from dominant, meaning you save money at the same time as you're saving infections, to highly cost-saving, meaning you spend a little bit of money, but you save a lot of infections, to not cost-saving at all. For example, dominant strategy, screening for CPE, carbapenemase-producing gram-negative. If you screen and isolate these patients, it starts to be cost-saving when the prevalence in your hospital is over 500, 1 out of 500 to 1 out of 1,000. So if in your hospital you have 2 or 3 CPE patients, it's probably cost-effective to start screening and isolating these patients. Under this, it becomes less cost-effective. One of the challenges we have in infection control is the decentralization of the IPAC budget. An IPAC team is typically an infection control officer, a doctor, with a head nurse, a few nurses specialized in IPAC, data manager, statistician, maybe a lab technician as well. But most of the budget of IPAC goes from other budgets, right? Lab will pay for the lab tests. The human resources for staffing will come from HR. All the disinfection equipment costs will come from technical services. And very often, there's no alignment between what IPAC wants to do and what the hospital is ready to do in terms of budget. And this is a constant fight between these two entities. Still, there are success stories, and I think we have to highlight them. One example of a success story, I'm going to go from Quebec because I'm from Montreal. So Quebec surveillance, huge decrease in bacteremias due to MRSA over the last 20 years. So it's the red line where, it's a bit fuzzy here. But the red line, which shows that MRSA bacteremia has decreased by 88% in Quebec over the last 20 years. The black line is Staph aureus, regular Staph aureus bacteremias, which you see has decreased also, but not in the same magnitude. Another success story, VRE control. So back in 2012, there was a lot of debate about should we stop screening and isolating for VRE. And some hospitals in Quebec just stopped screening and isolating. And what you see, the red area of the graph, is actually what happened, with a huge increase in VRE infections province-wide because of a few hospitals that were just driving the rates up. These hospitals went back to screening and isolating, and now they're back to rates that are the same that they were 10 years ago, or maybe more than that, 15 years ago. So this is a before quasi-experimental study, but that is kind of encouraging, because what's happening in terms of VRE elsewhere in North America, well, the story is completely different, right? In the United States, VRE is Enterococcus faecium. It's a special species of Enterococcus. In the United States, overall, when you have an Enterococcus faecium bacteremia or UTI or surgical site infection, 80% of the time it is VRE. It is the norm now. Enterococcus faecium in the United States is a VRE. What is the rate in Canada overall? 23% only, because most people are still fighting it. In Quebec, 6%. It is the exception. Granted, in the United States, there's only 35% of hospitals nowadays that are screening for VRE. And I know some of you are thinking, yeah, but it's VRE, it doesn't kill anyone. But what is happening right now, do you think, in the United States, since they stopped fighting against VRE? what is waiting us, right? How do you treat VRE infections? There are two antibiotics, linezolid and daptomycin. What's happening in the United States right now? Linezolid resistance is increasing. And now they're dealing with linezolid vancomycin-resistant enterococcus. This is an outbreak, Mayo Clinic. You would assume that they have good quality of care. One patient received months of linezolid for a VRE infection. The enterococcus became linezolid resistant, caused an outbreak on the ward, and even infected patients outside of the ward. So it's coming. And this is what you're trying to avoid here. The less VRE you have, the less linezolid you're using, the less you're triggering resistance to linezolid. This is fighting AMR. Still, we have challenges. These are like success stories, but we have challenges. One of the challenges, I have to say, really honestly, IPAC is damn boring and annoying. I know. Nobody goes into medicine thinking, I'm going to do infection control, right? It's like doing your taxes. It's not fun. And it's perceived as very burdensome by the staff. You have a lot of reasons to be against infection control, rashes, the discomfort of wearing the PPE, the annoying rules about jewelry, about the short nails, and they cannot wear some nail polish. People don't like infection control, and granted, some of our requirements are not even realistic, and we have to improve on this aspect. For example, hand hygiene in a high level of care area like the ICU might be even unrealistic. Some studies have calculated that for an ICU patient, if you took 24-hour period, all the people going in and out of the room and caring for the patient, it would require 500 hand hygiene per day. That's 4 hours per day spent just doing hand hygiene. It's not going to happen. You're not going to get 100% compliance. But still, there's a difference between trying and not being able to do it and not even caring about it. And there's a big laissez-faire about infection control and hand hygiene overall. Just to give you an example of how people tend to be dismissive of hand hygiene, let's look at how the New England Journal of Medicine is teaching medicine. For those of you who are aware, they have a whole series of clinical practice videos that teaches students how to examine a knee and how to do a lumbar puncture. Well, if you review these videos looking for hand hygiene indications, 80% to only 3/4 of the time, they don't even mention hand hygiene. And you have a sequence down there where you see the doctor just coming in and just shaking the hand and starting to examine a patient without even doing hand hygiene. These are supposed to be the gold standard, peer-reviewed, didactic material to teach students to work, and don't even show hand hygiene in it. The big challenge also, if we go pathogen-wise, is the carbapenem-resistant organism. The CNIS data that are available publicly, so I'm presenting only the ones up to 2022, is showing that, yes, it is increasing in Canada, but the increase is accelerating. So we're talking an exponential curve. You see, this is not a linear regression. This is an exponential formula, right? It is increasing, it is accelerating. And where is it spreading? It's spreading in hospitals. It's the orange line. You see that the other lines are community acquisition or acquisition outside of the country. But you see that the main driver, both of infections and colonization, is the orange line, which is nosocomial acquisition. So it's being transmitted in Canada within Canadian hospitals very freely. But now you're going to tell me, yeah, but it's happening worldwide, right? So we're no different than the rest of the world. But did you ever wonder, how are we doing compared to the rest of the world? Are we good or bad in terms of controlling the CPE? It's an interesting exercise. One way to compare countries between themselves, and I love it, is the ECDC approach. They took one pathogen, Klebsiella pneumoniae, one type of infection, invasive strains, and what's the proportion that is resistant to carbapenem. And they can compare countries between themselves. So here you see that there's a north-south gradient. Southern countries are like yellow and orange, are much higher rate. So yeah, countries like Italy and Greece, 25 to 50% of their Klebsiella invasive strains are resistant to carbapenem. Spain is about 10%. Portugal is 15%. But you're far from the Scandinavian countries that are under 1%. Where's Canada here? How would we compare? Do you have any idea where we are? We're good or bad? Well, we don't have exactly the same data, but we can pull out the proportion of bacteremias and CLABSIs in CNISP and compare. And this is our color. We were at 7% of our Klebsiella strains in CLABSI for CNISP were resistant to carbapenem. So I can't say that we're really doing super good right now. Granted, these are 2021 data for the ECDC, and Canada is 2024, I think, or 2023, so there's some time lag. But we're not a Scandinavian country anymore. It seems like we're more like a southern country. So I hope the trend is not going to stay, but there's something here, I think. There's a signal here that we should take this very seriously. And very rapidly, from our perspective, why is CPE that is spreading in our hospitals, why is it so difficult to control? And what are our blind spots? Because we're screening, we're isolating. So what are we missing? Is it a problem with implementation and recognized routes of transmission? Is it a problem the community that's spilling over in the hospitals? I don't know. Just going to raise two questions that highlight how complex infection control is. Maybe the problem is that we're not screening enough. And remember that you need about 10 to maybe sometimes 20 colonized patients to get a single infection. So to prevent transmission, you need to screen the colonized individuals. And there are some recent studies that suggest that we may not be screening enough. In the study that was published recently, where they did daily screening in the ICU, they got 30% more colonized individuals than if they only did admission and discharge screening. And you have this graph here where you see the orange dots are positive screenings for each patient. And you see that the phenomenon of intermittent carriage seems to be much more common and recognized. So maybe the problem is, among others, is that we're not screening enough. But then you have to convince the lab to increase the screening, and you have to convince the CFO to spend more money on screening, which is not necessarily easy to address. Another example, I think, which might be an elephant in the room, are the problem of the new reservoirs for transmission, which are the sinks, for example. I'm going to go fast here, but sinks are probably a source of transmission in hospitals. Patients are constantly exposed to sinks, and there's more and more studies that show that the environment around sinks is very contaminated by gram-negative bacteria that are resistant to antibiotics. The slide might be a bit small for you to see, but you see that the closer you are to a sink, the more likely you are to find gram-negatives that are resistant. And I'm going to just skip to one last thing, which is, I think, fascinating, is that there's some things that we don't even understand. For example, the seasonal trend. So the early winter right now that is hitting us is good for CPE. Why is that? Because there's a huge seasonal trend with more CPE transmission and infection during the summer months. So usually infection control, the problem months are winter, right? But for CPE, here, these are data from Korea, where you see really, really well that the positivity rate is increasing during the summer months, where you have the temperature, which is the blue line. And in Quebec, the same phenomenon exists. You have in the upper graph, you have the red line is the temperature curve, and the gray bars are the incidence rate of colonization of CPE. Well, you see an increasing trend, but you really see clearly the seasonal trend, the seasonal effect, with increase every summer months. And this really raises the question, which is not only theoretical, but potentially could lead to interventions. Why is there a seasonal trend? Is it that patients are more contagious in the summer because they sweat more and wet skin is more contagious than dry skin? Is it that bacteria survive longer when the humidity is higher during summer months on surfaces? Or is it the running water that's the source? Because water is not sterile, right? There's some bacteria in the running water. So I think here there's an entire phenomenon that should be looked into, because potentially it could help us identify ways to really fight DCP a bit better. So that's it. I hope that I gave you a little bit of an overview of the complexities of infection control. AMR, urgent threat, IPAC is important. We have done beautiful things in the past, but we still have some challenges ahead of us, especially if we want to fight against the newer pathogens like the CPE. And that's it.